Good afternoon. I'm Amanda Hall with the Communications Department here at the agency. I want to thank you for joining this webinar today regarding ACHN Provider Profiler Update, MARA Risk Scoring. Before we get started, I just want to let you know that all participants have been placed on mute. Please do not unmute your phones or microphones during the presentation. You may enter questions or comments in the chat box at any time throughout the presentation. However, questions will not be answered until after the presentation is over. Today's presenters are Connie and Courtney with the Quality Analytics Division. We will now begin the presentation with Connie speaking first.
Thank you, Amanda. Good afternoon. The main topic of this webinar is ACHN Provider Profiler Updates and MARA Risk Scoring. However, we are going to use this webinar as an opportunity to review and refresh the Quality Measure Profiler, as well as some of the updated timeframes for bonus payments. Today's objectives: review the TCP Payment Structure and timeline, review of attribution and quality measures, accessing Provider Profiler Dashboard reports, review of cost effectiveness and MARA methodology updates, update on changes to MARA risk score methodology, accessing Provider Profiler Dashboard reports, followed by questions and answers at the end. TCP Payment Structure. This is a bonus pool in the amount of $15 million annually, or $3.75 million distributed quarterly to the participating PCP groups. The bonus payment pool is paid quarterly and allotted as follows: 50% for quality, 45% for cost effectiveness, and 5% for PCMH recognition. PCP bonus payment timeline. The first quality bonus will be received in October 2021. The cost effectiveness bonus will be distributed in January of 21. The PCMH bonus, this is the first time providers will be receiving this bonus payment based on PCMH accreditation. It is scheduled to be released in the next couple of weeks. And also note, providers have to have PCMH recognition to qualify for the PCMH bonus. Attribution and quality measures, guiding principles of attribution methodology. Those principles are consistency with ACHN's principles of paying for activity, continued emphasis on care coordination and health outcomes with a focus on preventative care, acknowledgement that some recipients require specialist care, and evaluation of activities at the group level. Attribution overview. Attribution is the process that is used to associate a Medicaid recipient to the PCP group that provides primary care to that recipient. PCP groups must sign two agreements, one with Medicaid and one with the ACHN entity to participate. Under the ACHN program, Medicaid recipients are attributed to PCP groups based on historical claims data utilization. Also, PCPs are encouraged to continue seeing patients as medically necessary on a consistent basis to increase the likelihood of attribution. Attribution is a critical factor in determining distribution of bonus payments among eligible providers. As you all know, attribution replaced panel assignments. Under ACHN, the Patient First program ceased to exist and capitation payments were no longer paid, and that was as of September 30th, 2019. A smaller number of attributed members compared to members in the previous panel does not necessarily equate to a reduced payment. Guiding principles for quality metrics. The Centers for Medicare and Medicaid Services CMS collects quality measure data from all 50 states, and this is in an effort to strengthen quality of care and health outcomes. Specifications for the adult core set and the child core set are released annually by Health and Human Services, and these measures are validated and have standard specifications. The ACHN benchmarks are based on quality performance scores as reported by the various states and are adjusted as necessary. And the benchmarks are posted on our website, www.medicaid.alabama.gov, and will be updated on an annual basis. The primary focus is measurable, attainable improvement in health care outcomes. And to qualify for your bonus payment, PCP groups must achieve a quality score of 50% or higher. That means meeting the targets for at least half of the applicable quality measures. There are 8 provider quality measures, 4 child quality measures, and the child quality measures listed on your screen: well child visits in the 3rd through 6th years of life, adolescent well care visits, childhood immunization status, combination 3 with that one, and then immunization for adolescents, combination 2. The adult measures are antidepressant medication management, the continuation phase, the A1C testing quality measure, follow-up after ED visits for alcohol and other drug abuse, and chlamydia screening in women ages 21 to 24. Next is the timeline of quality measure periods used for quality measure profiler reports. So the timeline for the provider profiler quality measure scorecard, the supplemental member summary file, and the quality measures report card is as follows. So for Q1, FY21, we are in that now from starting in October of 2020. Those reports have claims data based on calendar year 2019. And this is also based on your attributed recipients for this quarter. And that is how that will go each quarter. So for the next 4 quarters, the data will be based on calendar year 2019. And then 1 year from now, starting in Q1, FY22, which will be October of 2021, we will move to calendar year 2020 claims data. And then 1 year after that, which will be October 22, we will move to calendar year 21 claims data. So back to Q1, FY22 in the yellow, in the pale yellow, that quarter is the first official bonus payment for quality measures. So that will occur during that quarter, the first official bonus payment for quality measures. Next, we'll talk about provider profiler dashboard reports. Provider profiler quality measure scorecard. This is a summary level that illustrates your current scoring. The member summary file for quality measures. This is the report that reveals how each individual affects your score. Then you have the cost effectiveness scorecard, and this is the summary level report for your scoring, and then the member summary file for cost effectiveness, and this report reveals how the individuals affected your score. These reports will be released next Friday, October 23rd. Next is accessing provider profiler reports through the provider web portal. The link, the website address is listed on your screen. To access the login panel, click Account and then click Secure Sites. And then once you're in, you'll navigate to your report. You'll click on Trade Files tab and the download option, and you will have an option to download the report as a PDF. And then towards the bottom, you will see the reports that you have access to. Then once you select the file that you would like to see, you will have the option to review that report. And here you will have the option to view it or download it as a PDF. Next, in this example, we are looking at Q1. So this report shows the provider's NPI number, the provider's name, and here we have the list of PCP quality bonus quality measures for you have your pediatric measures and your adult measures listed, and then the measure abbreviation, numerator and denominator, then your quality score based on that, and then this report also gives you the baseline and the benchmark and what improvement is needed, and it lets you know if you met that target, whether or not you met that target. Also, below, maybe a couple paragraphs down, where it says quality bonus payment calculation methodology steps, that's where you see you've learned that minimum quality metrics, you'll see what the minimum percentage is, and also this lets you know how many members were attributed to you. Next is the provider profiler quality measures recipient level detail report. So this report shows the Medicaid ID, it shows the birth date, and now this report does show the last name and the first name of the recipient. So that is a change to this report. The last name and the first name is now showing on this report. Also, you have your quality measure abbreviations, and this report gives you your numerator and your denominator for those quality measures, and which recipients met the criteria to be counted in the denominator and in the numerator. And then further details are also shown on the report. The zeros represent that the recipient did not meet the criteria, and the 1 represents that they did. And so below that, you get the count of who made up of how many people made up your numerator and how many people made up your denominator. And that is all I have. Next, Courtney will be presenting on cost effectiveness and updates to MARA risk scoring methodology.
Thanks, Connie. We'll start with just reviewing the guiding principles for cost effectiveness. We are looking to have consistency with the ACHN principles of paying for activity with a focus on preventative care and health outcomes. We're acknowledging that risk levels will vary across practices. Results are risk adjusted using validated methodologies, and we are evaluating activities at the group level. So we're going to just review a brief overview of the cost effectiveness process. All participating PCP groups are eligible for a performance payment if the PCP groups meet or exceed the cost effectiveness criteria established by Medicaid. Medicaid will be utilizing the Milliman Advanced Risk Adjusters, which is short for MARA. MARA is the abbreviation, and I'll probably be saying MARA for the rest of the presentation. So software to assess the cost risks of the ACHN population and apply a customized algorithm to calculate a cost effectiveness score for each participating PCP group. To qualify for the cost effectiveness bonus, PCP groups must have a score that's less than or equal to the statewide median cost effectiveness score. And so the cost effectiveness score incorporates the average risk of the PCP groups attributed recipients, overall per member per month cost of the PCP groups attributed recipients, and then also the overall PMPM cost of the statewide attributed ACHN population. The actual PMPM costs are compared to the risk-adjusted expected PMPM cost to determine a PCP group score. So what we're doing is comparing a 12-month per member per month to a risk-adjusted expected PMPM. Groups are then ranked by their cost-effectiveness score, and that's derived from the actual PMPM versus the expected PMPM for each group. And once again, the bonus payment is paid to PCP groups that are at or below the median cost. So we'll start by reviewing MARA risk scoring and then tell you about some of the changes. Risk scores are standardized metrics used to evaluate a member's previous health experience and or predict health outcomes depending on which risk score you use. Again, Medicaid utilizes MARA, which is Milliman Advanced Risk Adjusters. Every time that Medicaid runs risk scores, they get a prospective risk score and a concurrent risk score. Prospective predicts future risk, that's used in care coordination, but concurrent risk score is important here because it provides a singular standardized expected risk score given the past year's claims experience, which is why this risk score is what's used for the cost effectiveness bonus calculation. So here's a graphic just showing all of the information that goes into the MARA risk model. At the top, we have information about the person, the enrollee, the Medicaid eligible, their claim information, and I've highlighted diagnosis code, diagnosis sequence, procedure code, just so that you're thinking about that. And then there's also prescription information. All of this goes into the software, which is a black box that we can't do anything about, and then we get a risk score out of it. So the change that's coming is that the software is going to change. MARA has changed their model, and they will stop providing support to the old model that we've been using. Therefore, Medicaid is updating and using MARA version 4 software so that it is continued to be supported by Milliman. So what changes are coming? So the changes that MARA version 4 have is a total model recalibration. So MARA used more recent data sets that also includes more Medicaid data sets as they developed, tested, and deployed their new model. There are also adjustments to the age and gender baseline, so that top piece of the graphic, that baseline model that they have, that they use that for, has changed slightly. There's also further inclusion of lifestyle and social determinants of health claims. And then Milliman continues to provide patches to their software. The most recent patch has also added the COVID-19 diagnosis and also a COVID-19 likely diagnosis. And I just wanted to note, too, that these patches that are released with some frequency, they are regularly updated the model's use of NDC codes. And I just wanted to point out that the changes from version 3 to version 4 also include 6,442 new NDC codes. And if I remember correctly, a few of them are NDC codes that include drugs that are over $100,000 each. So what we've seen when it comes to this new version of MARA in the Medicaid ACHN population, this is the ACHN population, which includes both attributed and non-attributed members. We noticed that the version 4 has slightly lower average risk scores than MARA version 3. When we started to talk to Milliman about this, as a result of the model recalibration, they stated that this is because the underlying data used to develop the model is different, and then also the new model accounts for the way that doctors code, knowing that providers have adjusted their coding practices to the way that they are being evaluated. Okay, so when we're talking through all of this with Milliman, they have also suggested that we normalize the risk score specifically to the ACHN population for the cost effectiveness calculations. In doing so, Medicaid can more accurately compare provider groups within the participating provider groups of the ACHN. So a way to think of this is that raw scores will describe PMPM. So a risk score of 1 expects the statewide PMPM, and a risk score of 2 expects twice the statewide PMPM. But these normalized risk scores will describe the PMPMs within groups. So normalization will standardize the scale of comparison between all the participating provider groups in ACHN. Provider risk scores will seem higher, so will efficiency scores. The statewide median efficiency score will also seem higher. So the raw risk score shows how efficient you were, but the normalized risk score shows how efficient you were when compared to your peers, participating ACHN providers, ACHN providers, excuse me. And I would like to also note that there will be more providers within the entire provider population with an efficiency score above 1. So just to review, this is what your provider scorecard looks like. In the left column, we have the provider's PMPM as well as the statewide PMPM for comparison with all the different service types, including inpatient, outpatient, mental health services. Please remember that is by payment, not by diagnosis, pharmacy, physician, and then others. And then on the right side we have the practice risk score, of your practice, the expected PMPM, which is your the statewide PMPM multiplied by the practice risk score, and then your expected PMPM over your actual PMPM is your cost effectiveness score. And then below we show the median threshold and whether or not you meet the criteria. So the changes that are coming means that your practice risk score will now be the normalized practice risk score. And the cost effectiveness score and the median threshold will be higher than you've seen in the previous report. And then just as an academic, here are some references. And I do believe that the MARA brochure is on the ACHN website. All right, thank you. We will now begin the process of going through the questions that have come in through the chat box and providing answers. Please be patient while we go through this process.
The first question we have, I'm glad a provider brought this up. We do have a question that talks about the discrepancies, particularly around immunization registry and immunization data versus what the agency has. Medicaid, as you're aware, we do we bring in imprint registries, the vaccination registry that comes in from ADPH and match it. But I do want to have analytics discuss some of the issues we have encountered this year.
So I'm sorry, Drew, can you, what was the actual question that was posed?
Yes. We have experienced discrepancies with the data in our reports, vaccines given and reflected in imprint, but not showing up as given on our provider profile reports. What steps are being taken to decrease the incidence of these discrepancies?
Sure. I'll take a first stab at answering that, and I'll ask anyone from analytics to chime in, and especially if I state something incorrectly. So first, most of the quality measures are based on Medicaid claims data only. However, for immunization measures, we are utilizing imprint data to augment the Medicaid claims data, which is still ultimately the source of truth for most quality measures. However, we have noticed when we get the file, we have an agreement with ADPH to import the file on I think it's a quarterly basis, I could be mistaken, but we have noticed that because of some discrepancies, particularly in last names, there are some unmatched records. So we are currently working with ADPH in addressing these issues as best as we possibly can. However, I would note that there will still be some mismatches. We are dependent upon ADPH's 4-point matching process. So I would also note that Alabama is one of the few states that actually incorporate immunization registry data in producing quality measures. In fact, we were on a call with Mathematica a few months ago, actually, and there's a joint effort with CMS to encourage to evaluate states that utilize immunization registry with claims data, and to see if there's variance in the immunization rates and improvements in those rates for states that utilize that. So in short, what we found out is that we are one of a few states that actually do this. So in fact, by having this in-print data is augmenting what we do with claims data, which is actually what's done in other states. But to answer the question, we are aware of some of these discrepancies. We are somewhat beholden to the public health matching process, but we are continuously working with them to improve that process. But I would encourage every provider to continue, when you see these mismatches, to submit those questions to our provider assistance units, and they will either be able to answer directly or work with analytics to provide you an answer in a short time frame.
Thank you. And if anyone has any questions, please type them in the chat box. We do have a question. How is attribution measured?
So we evaluate a Medicaid enrollee's past 2 years of doctor's visits. This is only face-to-face visits for all providers, so primary, specialty, ACHN participating, non-ACHN participating, and we apply scores according to what type of doctor it is and how long ago they visited the doctor. Then whichever provider wins out, that's how they are attributed. We do have previous webinars that show this process more in depth. I'd encourage you to go to the ACHN website to look at those previous webinars.
All right. That's the only other question we have right now. And what Courtney did speak, there is, if you go to the Medicaid website, there is under a tab for ACHN and a tab for ACHN providers. All of our previous webinars have been posted, both the slides as well as the videos. Again, if you have any questions, please enter them in the chat box. We will be recording this presentation, so if you do have colleagues or others out in the community who weren't able to join us today, we will be posting this probably within the next 24 hours to our website, and we will be sharing the recording with the ACHNs so that they can share with their providers within their networks. And one of the ACHNs did let us know, yes, we do want to let all the providers know. One of the changes that the agency has been undertaking with all the ACHNs after our first year of implementation is going back and looking at some lessons learned. Well, one of those is providing the TCP attribution list as well as a copy of the profiler reports that each of the providers receive to the ACHN that they have signed an agreement with. So now your ACHN does have a copy of your attribution list as well as your profile report if you would like assistance to try and improve upon your cost effectiveness or your quality measures. All right. We'll wait a couple more seconds to see if any additional questions have come in, and if not, we'll end the call. All right, we haven't received any more additional questions, so there is an email address on the ACHN website if you would like to email. There are also, I know all the ACHNs have been going over these type of presentations with all the medical monitoring meetings, the medical management meetings. So if you have any additional questions, please also reach out to your ACHN and we can try and work with them as much as possible. So thank you for your attendance today. Like I said, we will be posting the presentation within the next 24 hours on our website. Thank you and have a good day.